Hi, everyone, and welcome to the Parkinson Foundation's PD Health at Home Wellness Wednesdays. Today's webinar offers an introduction and basic overview of Parkinson's disease. PD varies from person to person and changes over time. Today, we will learn what causes Parkinson's, the common symptoms, treatments that are available, and effective strategies for managing symptoms. We will also be introduced to practical daily living tips to navigate the challenges of living with PD. We want to thank today's webinar sponsor, Prevail Therapeutics, for supporting our mission. Before we get into it, I want to remind you about our other PD Health at Home virtual programs. Each week, we offer sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, expert briefings, and our Spanish language series, Ipi Salud en Casa. Be sure to visit our website to see what's coming up and explore our archived videos on YouTube. Help us spread the word and make a difference in our Parkinson's community. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. Thank you, PD Health. Thank you, Light of Day Foundation. And now I'd like to introduce our speaker for today's program. Dr. Reversa Joseph is a board-certified neurologist specializing in movement disorders and intraoperative monitoring. With expertise in Parkinson's disease, she takes an integrative approach to patient care. Dr. Joseph earned her BA from Columbia University, her MD from Georgetown University, and completed her neurology residency at Yale University. She pursued a fellowship in movement disorders at Georgetown, focusing on deep brain stimulation and botulinum toxin therapy, and a fellowship in clinical neurophysiology at the NIH, specializing in intraoperative monitoring. Currently, she is the director of the Movement Disorders Clinic at the Chalmers P Wylie VA, where she established a Parkinson's multidisciplinary care team to enhance care for veterans. Dr. Joseph is committed to health equity and addressing disparities in the care of patients with neurodegenerative disorders. Dr. Joseph, thank you for all that you do and for being here today.
Thank you. Okay, well, hello everyone, and I apologize for the interruption earlier, but I'm so excited to be here with you this afternoon to talk with you about Parkinson's, and I hope to be able to answer any questions that you have and have a great discussion this afternoon. You can advance the slides. Thank you. Okay, so I think Krista had kind of went over the overview of our learning objectives, but basically we want to really talk about what causes Parkinson's disease. We want to really go over the motor and the non-motor symptoms of Parkinson's disease. We want to talk about some treatment options, including exercise and other symptom management and other new advances that have come up, as well as kind of learning about having a multidisciplinary care team approach in the treatment and management of patients, and learn about what resources that are available and support for Parkinson's patients and caregivers. So what is Parkinson's disease? I like to describe this to my patients as this is a progressive brain disorder, or in our big word terms, we say neurodegenerative disorder. And that's just a big term to mean neurons in the brain are degeneration or degenerating. And so there's an area in the brain that helps to control movement. And that area kind of makes this chemical messenger called dopamine. And those dopamine nerve cells are dying. And so many reasons of why we think that's going on. But the loss of those dopaminergic cells is what we think gives most of the symptoms that we see with Parkinson's disease. Unfortunately, right now, there's no cure, but we do have a lot of good medications and ways to control symptoms. So the symptoms of Parkinson's disease can be treated. And most of the symptoms kind of can involve affecting one's movement, one's mood, as well as thinking. So your concentration, memory, those things can be affected as well. And we'll kind of get more into about motor and non-motor symptoms, but we understand that it's not just the physical things that we see that can occur with patients with Parkinson's, but also things that we don't see. So mood and memory and those things can be affected as well. But healthy lifestyle choices can really help patients overall maintain a really good quality of life. So I like to tell my patients that, that you can live well with Parkinson's disease. That's why I'm here. That's why the Parkinson's Foundation and all the resources that we have available are here to help you to really live well with Parkinson's disease. Next slide. So the cause of Parkinson's, we say that um, is multifactorial. We can't just pinpoint to one particular thing, but we think it's a combination of, genetic involvement, environmental factors that may increase one's risk. So we do know that there are genetic factors. There are about 10 to 15% of patients with Parkinson's disease that is due to an inherited gene mutation. So we have identified some genes that, if you have this mutation, you would develop Parkinson's disease. But that's only about 10 to 15% of patients. So we know that it's not solely due to a genetic cause, because other people that don't have that gene mutation can develop Parkinson's disease. So we see that there may also be environmental exposure. So for instance, I work at the Columbus VA here in Ohio, and I see many veterans, those that were in Vietnam and were exposed to Agent Orange. And we know that that is a risk factor for developing Parkinson's disease. So that is one type of exposure. Other here in Ohio, we have a lot of farming, and we have patients, that have had exposure to pesticides. We know that that is potential exposure as well as other types of toxins. And there's other risk factors. So being older in age, so patients usually develop this later in life, and also traumatic brain injury. So being exposed to, a lot of trauma to the head. So, many of you may know Muhammad Ali, had exposure to boxing and a lot of concussions, later developed Parkinson's. So, having that exposure to this traumatic brain injuries as well, we know it could be a potential risk factor for developing Parkinson's disease. Next slide. So what are some of the early signs of Parkinson's disease? And this, I really have been really trying to help educate our community about some of the early signs, because some of these things can just seem like, oh, this is just aging. And oftentimes when I, have a patient coming in with a new diagnosis, they're like, oh, I've had many of these symptoms for many years, and I never thought that it could be this. I just kind of brushed it off and, brushed it away and didn't even tell my doctor that I was having some of these symptoms. So we like to say, tremor, obviously, that's, not always just old age. So that's something to be thinking about if you're noticing a tremor. Sometimes it can just start as a thumb twitching, tremor, and then move to the whole hand. Small handwriting, we see that as a very common symptom that we can see with patients with Parkinson's disease, that they start out writing big, and then the handwriting gets smaller and smaller and smaller. Loss of sense of smell. So this is another risk factor that we can see in patients that have Parkinson's, but maybe later on develop Parkinson's. So they had lost their sense of smell 20 years or 30 years before they ever even developed a tremor. We can see that. Trouble sleeping, trouble moving or walking. So noticing that you're slower, you're not keeping up with your partner. You used to be the one ahead of everyone, and now, you're lagging behind your partner's way in front of you when you're walking together, or not being able to really keep up, noticing that you're tripping up, noticing that you're just walking really slowly and not really able to pick up your feet very well. Those could be some early signs. Constipation also is another very common symptom we see in Parkinson's patients. And having a low or soft voice, so, losing your ability to, really elevate your voice, to project your voice, seeming to get a lot of hoarseness very easily. And people are always asking you, what did you say? Having to repeat yourself because you're not speaking loud enough, your partner may tell you. The other symptom we can see is this masked face. So, having not a lot of expression in the face. And oftentimes the patient may not notice this in themselves, but their partner or family member or friends may notice that their facial expression is less to them. Dizziness can occur, so Parkinson's patients can get drops in their blood pressure upon standing, or changes in position can cause drops in their blood pressure, so they feel dizzy a lot. Some may even have fainting spells, but just dizziness. And then when you're walking, having this kind of stooped over posture, hunching over when you're walking, and not really being able to stand up really straight. And this is another thing that some patients may not even realize that they're doing when they're walking as well. Next slide. So, what you should know about symptoms. So, Parkinson's can affect many symptoms in the body. So, we tend to think, this is just again something that affects, motor things. So, the tremor, the difficulty walking, but it actually can affect a lot of other things. So, patients, we talked about can have constipation, so it can affect the gut, can affect the skin. They can have dryness of their skin, a lot of dryness, or skin conditions such as that. Again, it can affect their mood, can affect their memory, can cause sometimes even blurry vision. So just a lot of changes in the body. So it can affect, so not just the tremors that we see in patients, but other things can be affected as well. We call Parkinson's disease a movement disorder because of what we see, because it can cause tremors, can cause slowness of movements, can cause stiffness, or we say rigidity, but stiffness. And there's just that slowing when you're walking. Can also cause, issues with balance and your posture. So this is why we call it the term that it's a movement disorder. And symptoms can vary from person to person. So I just had a patient today that said, "Oh, well, my Parkinson's looks very different than other people that I've seen." And I had to say, yes, because every Parkinson's patient is different. They may not all have the same symptoms. Some patients may have tremors, some may not have tremors, but they can still have Parkinson's disease. Some may have a lot of issues with falls and their walking and their gait. Others may not have such issues with their walking, but the tremor is the main symptom. So all patients vary. So, not every Parkinson's patients may have the same symptoms. And symptoms can change and develop slowly over time. So, you may see different symptoms occur or develop over time. Next slide. So some of the motor symptoms of Parkinson's disease. So this is what, some maybe describe this as shaking, or, we say tremor. This can occur in the hands, can occur in the feet, can occur in the head, can occur also in the jaw or neck. So you can have a head tremor, a jaw tremor, so the mouth opening and closing. But this is what we tend to see in patients. So this is how we kind of recognize this in patients, especially the rest tremor in the hands. But it doesn't, not all patients have, their predominant feature may not be the tremor, but it is a very common symptom in Parkinson's disease. Other motor symptoms we can see again is the slowness of the movements. We call that bradykinesia. So, walking very slowly with, picking up something. Every movement tends to be very, very slow, and having trouble with either initiating the movement, or, just when they're walking, that is just, the walking is very slow and very, very labored with the walking. And a part of that component is because patients can have a lot of stiffness. So we call that rigidity. And that can be stiffness in the arms, stiffness in the neck, which we can call a dystonia, but stiffness in the neck could be in the arms and the hands. And so oftentimes if, you're seeing movement disorder specialists, they're examining you and they're trying to test your tone, seeing how, loose your muscles are in the arm and the hands and your legs, and hips. And so stiffness. And this can cause issues with patients being able to stand up from the chair, patients being able to roll over in bed or get out of bed or get out of the car. They can have a lot of difficulty because of this stiffness or rigidity. And then again, problems with their walking and balance we can see as part of the motor symptoms of Parkinson's. So what are some of the non-motor symptoms? And this is something I think we're beginning to make and pay more attention to as providers, because we see that some patients actually are not, they have the tremors, but the tremors don't really bother them. The tremor may not even be noticeable. It can occur at rest and they don't even notice that it's happening. So it's more bothersome to their care partner or a family member because they see it, but it's actually not that bothersome to the patient. Whereas some of these non-motor symptoms can be more troublesome to the patient. And one of those is mood. So mental health is a huge component that we really say that we're trying to make sure that we're addressing in patients with Parkinson's. Patients can have depression, nervousness or fearful anxiety, a lot of anxiety, and that can be very isolating because they're very anxious. They don't want to go out and socialize with other people, which we know is a very important part of being able to do. So they can be very anxious about that. Or they can have a lot of apathy. So patients that just lack, interest in doing anything, which can cause a lot of conflicts between the patient and their care partner, because their care partner may want to continue travel and do, all the things that they had planned to do, and the patient just does not have a lot of interest in doing these types of activities. So this is something that we can help to treat. There's medication, there's also therapy. So I'm a big proponent of making sure that we are managing and treating the mental health of our patients. As well as thinking and memory can be affected. Having some difficulty with paying attention, having difficulty with learning new things, being kind of slow in their thinking and their ability to respond or appropriately. Difficulty sometimes remembering words or remembering names of people, can't get the word out that they want to say, difficulty with getting the words out. So cognition or memory can be affected. And so this is something that we're constantly screening for in our patients, because there's therapy for this too, as well. There's cognitive therapy that you can do with the speech therapist, as well as there's medications that we can start. And sometimes other patients can have, again, trouble with their voice. So having a low tone of voice, they can't really project their voice very well. This can be treated, with the speech therapy. Patients can have issues with their sleep. So sleep can be a huge issue. So our sleep medicine doctors are our friends. We refer patients, make sure that we're treating if they have sleep apnea, we're addressing that, and other sleep issues that they may have, especially sometimes that falling asleep, just, could be talking to someone and kind of fall asleep. So definitely want to make sure we're treating that. And just the fatigue can be a major symptom, feeling sleepy a lot during the day. And some patients can also have hallucinations and delusions. And so we have medications that can help to treat that as well. And then constipation, again, is a huge symptom that we can see in Parkinson's. Next slide. So we have this term Parkinsonism versus Parkinson's disease. So what is the difference between this? So Parkinsonism really I describe as kind of a general kind of umbrella term to describe a group of disorders or diseases that have common symptoms. So the common symptoms would be the tremor, balance issues, stiffness, slowness of movements. And so the common group of disorders that have these symptoms, we kind of give that umbrella term Parkinsonism. And Parkinson's disease is one of the most common forms or diseases within Parkinsonism. So there's many different types of Parkinsonisms. And so I think that is why when you see Parkinson's patients, they can look different. And so there's different types of Parkinsonism. So, there's one, we call that multiple system atrophy. Those patients can have some tremor, stiffness, balance issues, but their main predominant feature also is difficulty with like fluctuations in their blood pressure, having very big swings, having a lot of low blood pressure and even sometimes high blood pressure. They can pass out a lot, have a lot of falls. of these patients. We also have another type of Parkinsonism called progressive supranuclear palsy. These patients can have a lot of issues with their eye finding, so have a lot of issues with being able to look up or down, so their eye movements are affected. Also, their swallowing can be affected. So there's different types of Parkinsonisms. Also, one due to having a lot of strokes can induce a patient to have a type of Parkinsonism. So due to vascular causes or because they had multiple strokes. So again, there's many types of forms of Parkinsonisms, but those aren't what we call typical Parkinson's disease. Those would be considered atypical. The typical Parkinson's disease, again, is the most common form of Parkinsonism, and the most typical form is called Parkinson's disease, that has the slowness of movement, stiffness, balance, difficulty, tremor, and it is a slowly progressing. So you're not going to see, with rapidly progressing within a year with typical Parkinson's disease. It's a slow progression. Now, there are some other forms of Parkinsonisms that may have a more rapid progression. And if we're seeing that in a patient, we're thinking, oh, they may have a more atypical Parkinson's. So hopefully that helps to kind of clarify that. Next slide. So the most common forms of Parkinsonism, so I kind of talked about that in the previous slide, but what we call the idiopathic Parkinson's disease, so that's just the typical Parkinson's disease, counts for about 85% of cases. And then we can also have drug-induced Parkinsonism. So there are patients that may be on a medication, maybe that's helping to treat their mood, to stabilize their mood. And these medications sometimes can induce a patient to look like they have Parkinson's, so can induce some of those symptoms: slowness of the movements, tremor, and the lack of facial expression, or the masked faces. So sometimes patients being on these medications, it can induce these symptoms to make them look like they have Parkinson's disease. And once with removing that medication, sometimes it can reverse that, sometimes not. And then the other one I talked about was multiple system atrophy, again, having issues with the blood pressure drops, and progressive supranuclear palsy, which I had mentioned, having the issues with the eye abnormality findings. I also talked about you can have a type due to strokes, having multiple strokes. Another form of a Parkinsonism is called dementia with Lewy bodies. And this one, Robert Williams, I think, was diagnosed with this. And this one, we tend to see hallucinations, memory problems very early on in the course of the disease for Parkinson's. So generally, patients with the typical Parkinson's disease, they're not typically in the beginning onset having a lot of issues with memory, or having hallucinations really early on in the beginning of the course of the disease. That can occur, but usually would be later on. Whereas a patient with dementia with Lewy bodies, their main feature was, issues with memory, issues, for a lot of forgetfulness, and then maybe behavioral things, and then maybe hallucinations, all these things starting very early. We're thinking more of a diagnosis of dementia with Lewy bodies. And then I guess, again, other rare causes, including toxin exposures, multiple head injuries, those sorts of things can also cause another type of atypical Parkinsonism. Next slide. So how is Parkinson's diagnosed? There's really no one way to diagnose Parkinson's disease, other than, we say that we do a clinical, the history, so do a good medical history and our clinical exam. So, with high confidence, we can do that based on your clinical exam and your medical history. We do, have some things coming down the pipeline with, skin tests and things like that to help us test for this alpha-synuclein and things. So that's not so widely used at this point. I think at some point it will be to really help us with the diagnosis, but it's really been mainly based on the clinical exam and the medical history. The other part is that we can get a DOT scan, which is a brain imaging. It's not necessary, but it can help us to support the diagnosis. And the DOT scan, you can go to the next slide, helps us look for evidence of loss of dopamine, so a dopamine deficiency. And that's what we're seeing in Parkinsonisms or Parkinson's disease. So if you look at the slide, I guess my thing can, I don't know if you're able to see this, but the left where it says consistent with essential tremor. You can see, I call them commas, thank you. I call them commas. They look like two commas on each side, okay? So that is a full looking comma, that's what I say. And so that area there is making they have dopaminergic cells there. And so in that patient has the tremors, but it's not due to a dopamine deficiency. So that patient has the essential tremor. So sometimes we do get the DOT scan to help us differentiate maybe an essential tremor type patient from a Parkinson's patient. But then if you look at the other three images, you see the first one. Yes, thank you. The first one is showing on one side, you're seeing the right side there, you're seeing the comma is not complete, it's not very full. And so that is an indication that that patient has a dopamine deficiency that we can see with Parkinson's disease. And again, the next slide or the next image next to that, we see the comma, both sides are not very full too. Another image showing that this patient has a dopamine deficiency that's consistent with the Parkinsonism. And then the third one's showing not very much at all there. So that's kind of a lot of loss of those dopaminergic neurons. So this DOT scan, we don't always get it because if our clinical exam and our medical history is fitting, we don't really need to get the DOT scan to just confirm it. But in some cases where it might not be so clear, the DOT scan can be helpful. Next slide. So when to start treatment? So really the decision to start treatment is a discussion that you should have, with your neurologist, hopefully you're seeing, or movement disorder specialist that you're seeing, and you. So it's a discussion between you two. And really, the goal of the treatment is really to help you manage your symptoms and to help you live well with Parkinson's disease. I tend to tell my patients that because there was this kind of thought process or you know, we have older, physicians, or just kind of the thought, I think many years before, was that you should delay treatment. Don't start yet because the medication later on is not going to work. So you want to delay starting treatment as much as possible. But we've had studies, that we've done since this time to show that no, it's not that the medication doesn't work anymore. And actually patients that, are starting on medication have a better quality of life than those that, delay and don't start any medication. So their disability is less when they're on medication and their quality of life is better when they're on medication. So we're not really proponents of delaying and not being on medication because the medication is not going to work anymore. It's not that the medication doesn't work anymore, it's that the disease progresses and that, we have to make changes to the medication to help further control symptoms of the Parkinson's disease. So we really try to change the school of thought of that. And then the treatment again, is depending on each person's symptoms. So I have some patients say, well, I'm on, 4 different medications and I have my buddy over here that's only on one. Well, his symptoms may be different from yours. And, the medications that we're able to use to control his symptoms may be we only need to do 2 or 1 for him. And so it's just different. So everyone's, dosing of medications, what type of medications may vary from patient to patient. So I like to really think of this as like tailored medical therapy. The therapy or the treatment is tailored just to you and your symptoms. Okay, we can go to the next slide. So the other thing that I think is very important in the care and the management of our patients with Parkinson's is building a healthcare team. So having kind of a group of medically diverse kind of providers to help you manage your symptoms, because as I talked about earlier, Parkinson's is not just the motor symptoms, so not just the tremors. Patients can have mood issues, patients can have memory issues, patients can have skin, dryness, patients can have constipation, patients can have issues with their vision, patients can have urinary symptoms. So, me as the one provider, I need the help of multiple specialists to help me in managing my Parkinson's patients. So, we have a multidisciplinary care team here at the VA that I help to assemble because, I feel that we need to make sure that our patients, all of their needs and symptoms are being addressed. And that's just more than just me seeing me. So other providers can help and share and providing their expertise in certain areas. So a team can include the movement disorder specialist, a general neurologist, a nurse, physical therapist, because we talked about the walking can be affected, a slowness of walking, balance issues. So our physical therapists really help with that. Our occupational therapists are also very helpful. Patients need assistive devices or learning how to, transfer, helping get out of the chair, helping with getting in and out of car, these types of things they can help us with. Speech language pathologists are very helpful, not only with helping with doing some cognitive therapy, but also with speech, because we talked about some patients can have that low tone of voice. Social workers are wonderful. They help us with all the other needs that we don't think about. Then we have our, psychiatrist and the psychologist to help patients with their mood. Also help the patient and the care partner, because sometimes a lot of conflicts can occur. It's difficult also for sometimes the care partner with having some of the burden of caring for a patient, and so just helping that family unit is also very important. And then the pharmacist also is a very important role on the team, because oftentimes we're prescribing many different medications, and they help make sure that we're not having contraindications with things, or maybe there's other medications that can be taken off that may be causing some side effects or symptoms that the patient is experiencing. Next slide. So, symptom management and finding the right doctor, I think this is very important. I like to think of this as kind of a lifelong kind of um, relationship that you're going to have with your provider, and hopefully you'll be able to sustain that relationship for many years. And so you want to be with someone that you trust, someone that is experienced, that knows how to treat patients with Parkinson's disease. So a movement disorder specialist has had specialized training in treating patients with Parkinson's disease. So usually you've done 2 or 3 extra years after finishing up your residency training in neurology. You do 2 or 3 extra years and just focusing on patients with movement disorders and learning about Parkinson's disease. So that's what a movement disorder specialist, the person that's had specialized training in treating patients with Parkinson's disease. And so, to choose the neurologist, you want someone who's going to answer your questions, who's going to, you know, um, make you feel comfortable, treat you obviously with respect. And so all of those things are important, that, you have a good relationship with your provider, and that you feel open to tell them about sensitive topics, about, things that are going on with you. We didn't really touch upon this one, but also there's also, the hallucinations sometimes patients are afraid to kind of talk about, but also the sexual dysfunction that can occur. There can be erectile dysfunction that happens. And so all of these things you want to feel comfortable with talking with your provider about. Next slide. So some of the treatments can include medications. Also, we have surgical treatments as well. So we have medications that can treat both the motor and non-motor symptoms, and we have surgical options to treat some of the motor symptoms. And then we have exercise and the therapy, which I love. So exercise is another medicine. I believe that, I mean, we've had studies also that prove this, that exercise is very important, very beneficial in patients with Parkinson's disease. And so physical therapy, occupational therapy, and speech therapy are very also important treatment management that we do for our patients, as well as the counseling that we talked about in the mental health therapy. Next slide. So some of the symptom management with medications. Again, Parkinson's patients can vary in what medication that they're on, the dosage of the medication they're on, even the timing that they take the medication. Levodopa, or carbidopa, levodopa is our mainstay medication. Levodopa gets converted into dopamine. We have many different formulations of levodopa, older one called Cinemet. Again, that's the carbidopa levodopa. We have extended release forms of this levodopa, one that's a Rytari, and other newer ones that have come out that are just longer extended forms of levodopa. We have dopamine agonists, so they kind of act like dopamine in the brain. They can kind of bind to the same receptors that that dopamine does, and so they mimic dopamine in the brain. And then we have MAOB inhibitors, which kind of stop the breakdown of dopamine in the brain. So that's another medication that can kind of, you take it with levodopa to help really to kind of keep it around longer, to kind of increase its effectiveness. And then we have a COMT inhibitor as well, increases the benefit of levodopa as well by trying to block its breakdown. So these are some of our kind of forms of oral medications that one could be on. You could be on a combination of all of them. So next slide. And then we have other surgical options. So sometimes some patients aren't well controlled with the medication. So we have some patients that their tremor is refractory to the medication, meaning that it does not respond. It may help with other symptoms like their stiffness or slowness of movements, but the tremor just does not respond to the medication. And those patients actually can do very well with the deep brain stimulation surgery. This is a surgery where we place leads in the brain, these electrodes, and then we have kind of, we implant kind of a battery, like looks like a pacemaker in the chest, and we're able to modulate the stimulation we give to that, those electrodes in the brain, and that can actually control the tremors. So patients also that respond well to levodopa can respond well to this treatment as well. It could be a patient that does respond very well to levodopa, but they're having to take it very frequently. And so those patients, if they opt to elect to have the surgery, can do very well and reduce their medications that they're taking. We also have a pump called Duopa, and that can deliver the carbidopa levodopa via pump into the intestine. So it bypasses the stomach because many patients can have, we talked about the constipation, but also delayed emptying of the contents that are in their stomach into the intestines. It can be delayed. So therefore you take a medication and hour, 2 hours later, that pill is still in the stomach. It had not been absorbed. And we can see this by doing like a scope, and we can see that the medication is still there. And that's why the patient hasn't had good benefit or feeling like they've turned on or the medication is working, because the pill is still stuck in the stomach. Or hasn't been absorbed. So the Duopa helps to bypass the issue in the stomach and delivers the medication in the intestine and through a pump delivery system. So that we have that out, and actually a newer form came out that's called Vyalev, that was recently approved sometime, I think October, November timeframe, and it's a subcutaneous delivery of the carbidopa levodopa. So we have 2 pump systems. Next slide. Other symptom management is through exercise. So we know that exercise helps to maintain one's balance, their mobility, their strength, and their flexibility. Exercise, also can help relieve symptoms like the constipation. We know that exercise is, good programs can include stretching exercises, aerobic activities, so getting your heart rate up, resistance training, also biking, running, tai chi, yoga, Pilates, dancing, weight training, boxing. I don't know if anyone's heard of rock steady boxing, qigong. These things can be very effective forms of exercise. So, but the main thing is pick something that you enjoy. So we may say, oh, you should do this, you should do the tai chi, you should do the yoga, but really pick something that you enjoy and that you're going to stick with and that you're going to do. Next slide. Another thing is nutrition. We recommend that patients stay hydrated. So sometimes some of the symptoms of feeling the lightheadedness or the dizziness can be to dehydration. Patients just aren't drinking enough. Sometimes they don't drink enough water because they don't want to have to go to the bathroom all the time. So they feel like they're urinating too much, but they actually still need to be drinking the water. So we recommend about 6 to 8 glasses of water per day. Also, to help with the constipation and just to help things move smoothly, we recommend that you increase your fiber intake. So, eating a lot of whole grains, vegetables, and fruits. And then patients always ask me, well, what kind of good food should I be eating? I would say that things that are anti-inflammatory and things that have antioxidants. So things that are anti-inflammatory are fish and the omega fatty acids are what's good in the fish. So salmon and tuna. Also, dark green leafy vegetables are antioxidants, and having like purple and red fruit vegetables are also very good as well. And 5 steps to living well. So, and you can really pick this in any order that you choose. But we say that really determine your goals. Think about what's important for you, what's important for your life and your family. Um, Pick an expert, a expert, or like finding the Parkinson's expert, meaning that the Parkinson's Foundation can help you finding a good movement disorder neurologist, if that's not in your area, a general neurologist, but someone that has the experience with Parkinson's patients. And then finding someone to talk to. We really, don't want you to be isolated. We don't want you to be going through this alone. Again, the Parkinson's Foundation has support groups that they can help you to find in your area. And just connecting you with other people is that connectedness is so important. And then creating healthy habits. So we talked about nutrition, getting good sleep, and just taking care of your emotional and mental health as well. And then I think the most important is just being active. Picking an exercise program, whatever that works for you, but something that you enjoy and something that you're going to stick with and continue through, because the exercise component is so important to helping you maintaining your mobility, your strength, and helping overall improve the quality of life. Next slide. So hopefully some key takeaways is that Parkinson's disease symptoms can be managed effectively. I know we say that we don't have a cure, but we do have medications that really help us manage patients' symptoms of Parkinson's disease to help patients really live well. And again, symptoms can vary from person to person, including the movement symptoms as well as non-movement symptoms. So we talked about the motor and non-motor symptoms. And then really that, the treatment approach is personalized. I say that it's tailored pharmacologic therapy. So it's tailored just for you. So what you're taking may be different from your friend. It may not be the same, may not be the same medication, may not be the same dosing. And we really recommend that comprehensive multidisciplinary care team approach, having a team of providers around you, and I think is great for the best kind of long-term outcome for our patients. All right, well, I think that ends that. If there's any questions, happy to take that at this time.
Thank you, Dr. Joseph. There are so many subjects in the field, in the community, in the livelihood of Parkinson's disease, and I really appreciate the way that you've condensed the information so that we can begin to feel, introduced properly to Parkinson's. There was one question that came in from one of our guests today, specific to diet. Could you share how diet or what we eat might interact or impact Parkinson's disease?
Okay, yes, very good question. And so you may hear your provider say, that protein can interfere with the absorption of the carbidopa levodopa. So protein can interfere with the absorption of the levodopa, so the dopamine. So we recommend, it's not that you can't have protein, you can have protein, but we recommend spacing it out between the times. So if you're going to take your carbidopa levodopa, if that's the medication that you're on, we recommend if you take it, then wait about an hour or so, and then eat your meal, whatever that protein meal is. Or if you're going to eat first, go ahead and eat first, and then wait about an hour, and then take your carbidopa levodopa. We just don't recommend that you take them both at the same time. People feel that they have to eat something when they take their pills. Some people just like to do that, and that's fine. You can.
Mm.
We just don't recommend it be a protein-rich meal when you're taking your medication, not at the same time. So you can have a cracker or a bread. I tell people applesauce if you just need to take something with the pills or pudding, but just not protein at the same time.
Mhm. Yeah. Thank you for answering how protein can impact the way that we absorb the medication to help support our symptoms with Parkinson's.
Mhm.
This is a common question that comes up with Parkinson's disease, and one I'm sure you hear very often, Dr. Joseph. But how common is urinary incontinence in Parkinson's patients?
Mhm. Well, it just varies, because again, our patients, again, they're getting this diagnosis later. And so oftentimes I'm seeing patients too in their 70s and some even in their 80s. And so, a lot of just common things happen at that time that aren't necessarily related to Parkinson's disease, but they have that as just a natural part. So arthritis, a lot of people have arthritis. It's not just related to Parkinson's because you have arthritis. So the urinary incontinence, not every patient may have that. They may have a lot of urgency, and the symptom can be different. They can have urgency, frequency, but make it. But then sometimes if that progresses, then they can develop the incontinence. But then we can have some patients that have difficulty urinating, meaning that it's not coming out.
Mm.
So some of our men can have more of the issues with the prostate. So it just varies. So the symptoms that they may experience may be different, but urinary incontinence can be common. More times, often it's the urinary urgency and the frequency that can lead to some of that incontinence that we might see.
Okay. That's really helpful to hear. Thank you for clarifying that, Dr. Joseph. There are lots of questions about medications here, and some so specific that I'm afraid to offer them to you. What I would love to not afraid, but I understand that there's a lot that we need to know about a specific case in order for us to consult each person on the types of medications that they're on. So I'll offer you more generic ones, Dr. Joseph. Can why does let's start with does levodopa help with mood or only physical symptoms?
That's a very good question. So, we say that it can help with mood because dopamine actually can help improve mood. So, dopamine, again, is this chemical messenger in the brain we all make. And dopamine actually is involved in that kind of reward pleasure system in our brain. So, it can improve our mood. Low levels of dopamine also can lower the mood. So yes, so it can help improve mood. So it's kind of twofold. We're not using it necessarily to be improving mood, but that could be a potential result of that. But we
Mm.
have other medications to really address mood if the patient has depression. We're not using levodopa to treat their depression. It may help some aspects, but we wouldn't be only using that to treat depression
Mhm.
because levodopa is used to treat more of their motor symptoms. But
Mhm.
as a kind of another benefit, it may also help with mood, but it would not be what we would be using solely to treat their mood symptoms.
Okay.
Mhm.
Following up from that, someone's asking, why don't dopamine replacement drugs help with non-motor symptoms of Parkinson's?
Why don't the dopaminergic, repeat that
Yeah.
again?
Why don't dopamine drugs like Cinemet help with non-motor symptoms of Parkinson's?
Well, I mean, they may help with some, but not all of the causes may be specifically due to, the lack of the dopamine. So, the skin irritation, you know, that may not be an exact cause of, the lack of the dopamine there. So there's different kind of chemical processes that are going on and different other reactions that are going on. So it may help with some things, but no, it's not the end all catch all for all of the symptoms that are happening with Parkinson's. So no, it's not going to help solely with, the cognitive symptoms, the memory loss. No, because there's other chemical messengers that are, in place or out of place that are involved with the memory system.
Mm.
There are other chemical messengers that are involved in some of the other aspects that we're seeing. Dopamine is a huge player, but there are other, neurotransmitters that are involved in these processes as well. So yes, we're able to not measure, but like in a sense, we call it a dopamine deficiency because, we see that on the DOT scan that it's a evidence of dopamine loss and those nerve cells are dying. But there are other players, like meaning other chemical messengers that are involved in the whole process, not just dopamine. So that may explain for why it doesn't help with everything else. Doesn't help with, all of our urinary symptoms or constipation or vision changes, unfortunately doesn't help with it may help improve some, but it's we still have to use other things to help with those things. So constipation, we may have patient be put on Miralax or some stool softener. Vision problems, they may have to get prisms. So it's just different things.
Yeah, what I'm hearing, Dr. Joseph, is it is essential to understand the function of the drug that you're invited to support a very specific symptom, and that there's other drugs with specific functions to support other symptoms of Parkinson's disease.
Right, right.
Okay.
Mhm. And sometimes it may not even be a drug that we're using to help treat that thing,
Mm.
treat that symptom, I mean. So for instance, like I said, that, with the vision, we can help to correct those things by the glasses. So sometimes we're having the double vision. We're not necessarily giving you a medication, we're changing your prescription glasses. So there's different things to help treat that, like the balance. We're not necessarily giving you a pill to help with that. We're doing physical therapy. We're recommending yoga. We're recommending Tai Chi. So sometimes the medication doesn't treat everything. I tell my patients, I wish I had a magic pill that could just treat everything. But no, it's not that way. Sometimes we have to use our therapy, our exercise, our nutrition to help treat certain things.
Yeah, and this segues really nicely into a question that another attendee member just asked is what natural treatments can you recommend for constipation?
Oh, that's a really good one. So, and I think the Parkinson's Foundation used to have this recipe for it was like with using applesauce and prune juice. I'd have to go back and look at the book, but basically,
An elixir.
yes,
An
yes,
elixir
like
to
it was
help you
natural.
poo.
Yes, it was. It was like applesauce and prune juice, but I
Yeah.
think the main thing is like increasing, the fiber. But if patients do things to increase the fiber, which is very good, you have to drink a lot of water because
Yes.
you want to be able to move. You're bulking up the stool, but you want to be able to move that through your gut. And so drinking a lot of water. So one, increasing your water intake is going to help. Two, increasing your fiber intake. So eating those, green leafy vegetables. And then two, another one is the prunes. So some people like eating prunes or drinking the prune juice. That can be very helpful.
Mhm.
So those are, I would say, some of the more natural ways to improve it.
That's great. It comes up time and time again, Dr. Joseph, of the need to drink more water. So, an invitation to take a sip of water at this now moment.
Mhm.
And thank you all so much for the questions that you're offering us. I'll be transparent. We will not get to all of them today. So an invitation to reach out to the Parkinson's Foundation's helpline to get some more answers to your questions. There is a question that came up early on when we were talking about slow speech to Dr. Joseph. Can PD also cause sort of a worsening and stuttering when we're speaking?
Mhm. So patients can have a slowed speech, so difficulty with the speech production, but also a stuttering. And we can see that. So fast, like kind of stumbling over the words uh, as well. So yeah, so some patients can have a worsening or even just a development of a stutter that they never really had before. And that's interesting because too, patients, even with their walking, can have slowness with their walking, but then some patients can have that stuttering too when they're walking. They speed up very quickly and they can cause them to fall so
Mm.
that they have this like fascination where their gait their feet just kind of move like this very quickly, and it causes them to fall because they can't get out of that repetitive motion to take a step, and then, and so that can actually cause them to fall. So that's interesting how even though the movement at sometimes can be very slow, they can like have this very fast movement that causes them to fall because they actually can't control the movement. So
Right.
it's this incoordination of the movement. But
Mhm.
yes, we see that also too with speech.
Yeah.
And speech therapy can be helpful for that as well.
Yeah, very helpful. Thanks for differentiating how stuttering can, it's not only just about the voice, but also the body and the way that we move and navigate in space.
Yes.
Um, Dr. Joseph, I want to address our community here, recognizing there are many very specific questions here on topics that go beyond a basic overview of what Parkinson's disease is. And at the foundation, we offer in-depth, or what we call deep dive webinars about aphasia, stuttering, speech, and swallowing, obsessive impulsive disorders, Parkinson's medications, mental health, you name it. The Parkinson's Foundation has very specific resources to the questions that I'm seeing here come through. So, Dr. Joseph, as we near our time, our end of our time together, is there anything you'd like to share, sort of a last sentiment to our community here today?
Yes, I just, want to say that it's, to me, a very exciting time just in the treatment and management of patients with Parkinson's disease in terms of just what tools we have in our toolbox to help patients really live well. I think that also too, it's a very exciting time in research and what is kind of out there being developed right now. So a lot of things very promising, even on the side of genetics. We're learning a lot more on that end as well. The Parkinson's Foundation has a great PD gene study. So a lot that's going on in research, a lot that's going on in the treatment and development of new drugs that are in the pipeline. So very excited about that, and just excited about what we have now in our arsenal of new drugs that have just come out over the last couple of months. So I just say that, want to be encouraging to our patients and our caregivers, that the support and the resources are there, even through the Parkinson's Foundation. Get connected with a good provider, and because I really, it's a family. Like, I look at my patients, it's truly a family because we're with each other for the long haul, and so really encourage you to get with a provider that you trust and that you can work with, and that you feel comfortable with, because we want to provide the best care for you and want you to live well with Parkinson's disease.
Thank you, Dr. Joseph. I really appreciate all that you've done for our community and continue to do beyond Columbus, Ohio. So appreciative of your commitment to supporting the Parkinson's community. And thank you to all of you who joined us today with the courage to come into this space to learn more about Parkinson's disease, whether that's for yourself, for a family member, friend, loved one, colleague, peer. You showed up here with curiosity, and I want to celebrate that. And I want to give thanks to today's webinar sponsor, Prevail Therapeutics, for supporting the mission of the Parkinson's Foundation. Thank you, Prevail. Uh, Dr. Joseph mentioned the important role of research. And as we wrap up our time together, I'd like to take a moment to share some important trials that we have happening here at the Foundation. The Foundation remains dedicated to educating and expanding opportunities to deepen our understanding of Parkinson's disease, and we can't do that without you. Your engagement in Parkinson's research plays a crucial role in advancing treatment options and bringing us closer to a cure. I'd like to highlight just a few ways you can get involved and help drive progress in the Parkinson's community. The first to mention is our PD generation study that offers free genetic testing and counseling for Parkinson's related genes to help with Parkinson's. This groundbreaking initiative is helping us uncover more about the genetic factors behind Parkinson's disease. By participating in PD generation, you can learn if you have a genetic link to Parkinson's with no long-term commitment and full confidentiality. The genetic test results provide valuable insights into your symptoms and potential progression, helping you and your care team create a personal personalized treatment plan. This study is also advancing research by helping scientists understand why experiences with Parkinson's vary from person to person. To achieve this, it's essential that we have diverse participation. So diversity, we know, is key to building a comprehensive understanding of Parkinson's and ensuring that future treatments work for everyone in our community. If you're interested in PD generation, visit the website on the slide or call 1-800-4PD-INFO to learn more and to get started. And now shifting to another opportunity to push research forward, the Parkinson's Foundation is proud to partner on Persevere, a new NIH-funded study for family caregivers of people with Parkinson's disease experiencing cognitive changes, hallucinations, or dementia, or caregivers of people with Lewy body dementia. Persevere is committed to including male caregivers, rural caregivers, and caregivers of color, groups often underrepresented in research. You can learn more and see if you qualify by visiting the Persevere website, scanning the QR code on the screen, or emailing that email there also on the slide. Let's support caregivers and spread the word. Before we wrap up, I have one last favor to ask you, recognizing that your feedback is essential to shaping the Foundation's programming. As the webinar concludes, a survey will pop up on your screen. Please take a moment to share your thoughts and let us know what topics you'd like to see in future sessions. Thank you so much for joining us today. We're honored to have shared this time with you and hope you found the information and resources helpful on your journey. Please know that you are not alone. Our community is here to support you every step of the way. Your strength, resilience, and dedication inspires us, and we are grateful for the opportunity to be a part of your journey. If you have questions that did not go answered or need additional support, don't hesitate to reach out. Together, we can navigate this path and continue building a brighter future together. Until soon, my friends, take care and be well.